Hello, I'm Manoj Karmakar. In this next video, Dr. Yang from the Yonsei University School of Medicine from Seoul in South Korea is going to discuss with us the anatomy of the thoracic paravertebral space as revealed using 3D micro CT. Indeed, Dr. Yang is an anatomist, and he and his group have truly redefined the anatomy of the thoracic paravertebral space. I hope you find this useful. In case you are enjoying our videos, do remember to like and share these videos. Also, if you still haven't subscribed, do remember to subscribe so that you can get regular notifications of any future uploads.
Nice to meet you, doctors. Thank you for giving me this honorable opportunity to be here in SPS. I'm Hong Yang from Korea, Yonsei University College of Medicine. Actually, I'm not a clinician, not an expert in pain medicine. I don't know block techniques very well. So today, just as an anatomist, I will just show you my technical experience for the study of the paravertebral space. Previously, I used classical method, manual dissection or shallow stain technique to investigate nerve or vessel distribution. 3 years ago, I thought two ways my anatomy lab should go. First, improving the observational tool, and second, collaborating with clinicians. After trial and error in this year, we can provide detailed anatomy of the paravertebral space using our micro-CT technique. So what I talk about today is how to apply the micro-CT method for investigation of the paravertebral space and how to collaborate with a pain physician to help other clinicians. My old research topic is about small muscles and fascial connective tissues in the face. Unfortunately, these vulnerable structures would be very easily deformed or easily destroyed by a manual dissection. So my team had been looking for a better way that satisfies non-invasive approach, high-resolution images, and multi-direction observation. We found the micro-CT may be a good choice. It can provide minimum 5 micrometer box cell, very high resolution. As a kind of CT tool, the micro-CT has all those conventional CT's advantages, but mostly it has been only used for hard tissue observation because soft tissue has very low contrast in the CT, so not detectable. We found the contrast enhancement make the soft tissue very distinct in the CT image. So my team optimized the image enhancement protocol of the soft tissue using a contrast agent. By reviewing my previous studies of the facial anatomy, I briefly explain the steps of the micro-CT procedure. First, we harvested the sample. In this case, we did not remove the skin. Whole tissue, including skin, subcutaneous tissue, muscle, fat, and bone with the periosteum, they are harvested and blocked. Second step is to enhance tissue contrast, soft tissue contrast. Next step, micro-CT scanning. We used SkyScan system that can scan down to 5 micrometer voxel size. Thousands of individual sectional images could be obtained by the SkyScan system. And then the final 3D volume image was rendered by the reconstruction software, and proper section, proper area was chosen for optimal visualization. This image is from a very delicate soft tissue, lower eyelid. Up to now, we have studied the face using this technique, micro-CT. Meanwhile, my team and I, my anatomical team, decided to collaborate with a pain physician, Professor Kim Shin-young of Severance Hospital Pain Clinic. We worked together as a translational research unit for clinical anatomy related to pain management. At first, we simply reported topography of anatomical structures for safety or efficient sites to be injected. We measured numeric items for structures location and provide their expected occurrence. Or we used the Schiller staining technique that can comprehensively visualize the nerve twigs within the muscle. However, these measurement studies seem to be useless. Actually, useless, we think. We thought individual customized anatomical information would be more important. This is why we used ultrasound imaging. So in 2018, we tried to compare two paraspinal nerve blocks using cadaveric injection. We compared anatomical spread of dye in thoracic region following ESP block and lateral laminar block. Lateral laminar blocks and ESP blocks were performed on the left and right sides of non-fixed cadavers. 20 milliliter of dye solution was injected at the TV5 level with ultrasound imaging. After then, the back muscles were dissected. We observed the fascial spreading in the back muscles in both techniques. The involvement of thoracic nerve was also investigated. Although ESP blocks had a slightly larger number of stained thoracic nerves, but both techniques revealed limitation of spreading to the PVS with posterior spreading to the back muscles. Agent delivery to the PVS would be a common anatomical principle of spinal nerve block. Next study, we provided a direct visualization of the PVS by endoscope. Here you can see, figure T, you can see the intact PVS. The ESP block with dye was performed with ultrasound imaging, and then immediately the PVS was observed by endoscope. We can directly observe the spreading of dye into the PVS after ESP block. As expected, the paravertebral spreading following ESP block increased in a volume-dependent manner. Of course, injection size, volume, direction, these are significant factors for successful blocks, yes, for clinicians, but I was more interested in the PVS anatomy itself. Actually, the term paravertebral space, PVS, is not legislated in the terminological anatomica, nor described in Great Anatomy, the established anatomy textbook. This is not an official anatomical term. Nevertheless, it has been broadly, frequently used in the clinical field. We borrowed the PVS concept from credit team in their monumental review in thoracic area. The vertebral body and intervertebral foramina form medial border of the thoracic PVS, TPVS here. And parietal pleura form its medial border. And superior costal transverse ligament, SCTL, which connect with the internal intercostal membrane. The SCTL is the posterior border of the thoracic PVS. Actually, there is an endothoracic fascia between the rib and the pleura. This fascia is a thin connective tissue layer. So in my opinion, it seems to play a role as glue between the rib and pleura. So although an endothoracic fascia is kind of potential extension of the TPVS, but I think, in my opinion, physiologically, there would be less space between the rib and pleura. Anyway, these three borders make a narrow triangle of the TPVS. It has major nervous compartment, including spinal nerve, dorsal ganglion, and even sympathetic ganglion. Although there are many brilliant studies about the PVS anatomy, but we wanted to show its anatomy more comprehensively with multi-directional approach that can reveal proper sectional image. Also, we tried to verify detailed morphologies of these sections using histological examination. Of course, conventional manual dissection would be still the most intuitive method. In addition, an injection study could give us important clues. By all these approaches, we tried to revisit the PVS anatomy. We tried to verify previous findings robustly and to present three-dimensional anatomy of the PVS more intuitively. This is a spine structure image. The pleura was removed. You can see the SCTL and its medial slit and lateral slit, and we found the costo-transverse space with a distinct dense connective tissue here, and ventral lamina of spinal nerve pass via the medial slit. Yeah. The SCTL formed posterior wall of the TPVS, but it was an incomplete border. In credit study, there was a gap here, gap between the SCTL and vertebral body. This gap has been known as the costo-transverse foramen, CTF. Paraspinal muscles, including iliac spinae or multifidus, they are located posterior to the TPVS. So SCTL might be a boundary between TPVS and this back muscle compartment. However, some studies, including credit study, showed a narrow space posterior to the SCTL here, and you can see here. This small space could be filled with connective tissue. It did not seem to belong to the muscle compartment. It's a kind of transitional space. Accordingly, we found the SCTL here incompletely formed a part of a posterior wall of mentioned medial slit here. Medial slit of the SCTL corresponded to the costo-transverse foramen CTF. The ventral lamina of the spinal nerve was observed to exit through the CTF and enter the TPVS. The CTF or medial slit seemed to be very close to the intervertebral foramen. We found another slit of the SCTL, and it was named the lateral slit. Actually, SCTL was located very close to the pleura. So the TPVS appeared to be a narrower space than previously known. We found the intervertebral ligament here, the ITL, to be located posterior to the SCTL here. The ITL was narrow, distinct ligament that attached neighboring tubercles. Some twigs of dorsal lamina of spinal nerve passed between the SCTL and ITL. You can see it. At the TV5 to fiber level, we observed consistent topography of the ITL, and two layers of the SCTL in sectional anatomy, histological findings, and micro-CT imaging. The SCTL originated from the superior surface of the fifth slip. From this common origin, anterior and posterior layers diverged, and the anterior layer was attached to the lower surface of the fourth slip. You can see also in histological findings. And the posterior layer of the SCTL was attached to the transverse process of the first thoracic vertebra. The ITL was originated from the lower transverse process and attached to the upper one. Here, here, and here. The TPVS was located between the SCTL anterior layer and pleura. In this video, you can see distinct two layers of the SCTL. They are marked as blue color, anterior and posterior layers. Anterior and posterior layers of the SCTL. You can see it. The medial slit of the SCTL here, or previously known the coastal transverse foramen (CTF), was clearly shown in the micro CT and manually dissected specimen. The ventral lami of the spinal lobe was passing through the CTF. After exiting the CTF, the ventral lami connected with the communicating lami here. This is another sample. The CTF appeared as a slit or foramen between fibers of the SCTL. The CTF, here, the CTF was very close to the radiate ligament or costal head. In this video, the pleura remained between vertebral body and pleura. The intercostal vessels were observed here. The TPVS was shown between the pleura and SCTL, and intercostal vessels and ventral lami was shown within the TPVS vein and artery. From the anterior side, a posterior intercostal artery and vein and ventral lami that forms intercostal nerve. They are shown beneath the pleura. After removing the pleura, you can see two slits of SCTL, also clearly shown here. Medial one, also known as the costal transverse foramen, and lateral slit of the SCTL. So far, it's known that there is ligament tissue between proximal part of rib and transverse process. It has been known as costal transverse ligament here. However, in our study, there was no distinct ligament tissue within this space. We define this space as the costal transverse space, CTS, although some faint fibers of the SCTL cross the base of the CTS, this space here, some faint fibers. This space was mostly filled with loose connective tissue or adipose tissue. You can see in the histological section. So we can speculate that this space, the CTS, could be a route for intersegmental spreading. In summary, we observed the potential spreading space between the space, SCTL and back muscle compartment. Here, we termed it retro SCTL space. The retro SCTL space was consistently observed in the micro CT and ultrasound imaging here, and this sectioned specimen here. This space broadly connected furtherly TPVS via the CTF here and directly connected to the intervertebral foramina and backwardly the back muscle compartment. The ITL and the dorsal lami of the spinal lobe were located within this space. In addition, neighboring lateral SCTL spaces are vertically connected each other via the CTS. Previously, some clinicians recommended the injection targeting the space posterior to the SCTL. ASRA and ESRA delta consensus reported in the RAPM define an injection posterior to the SCTL as the intertransverse process block, ITL block. To confirm our findings in which the lateral SCTL space communicated with the DPVS, intervertebral foramina, and back muscle compartment, we performed the ITP block to inject the dye into the lateral SCTL space. After then, ambulant resection of the posterior body wall was performed, and this dissected posterior body wall was defrosted, and 1 centimeter 6 serial sections were obtained. And then paravertebral dye spread was evaluated. Specimens showed a distinct staining pattern that highly corresponded to our anatomical findings. The dye fully surrounded the dorsal and ventral spinal of rami, is spread to the paravertebral region and like here, and intensively stained the sympathetic trunk. We found the segmental spreading from the lateral SCTL space injected site to the DPVS through the CTF and back muscle compartment and the intervertebral foramen. We could also observe spreading to the epidural space via the intervertebral foramen. In addition, there was dye staining pattern that implied the high feasibility of the intersegmental spreading, vertical spreading. First, the CTS was distinctly stained. As mentioned before, the CTS was mostly filled with the loose connective tissue and adipose tissue. This dye spreading pattern within the CTS strongly implied that the CTS could be an intersegmental conduit pathway in the ITP block. Second, the dye continuously stained the epidural space in some serial sections. Third, some levels revealed staining in the endothoracic fascia between the lip and pleura. In summary, we found horizontal spreading route to the DPVS or back muscle compartment from the lateral SCTL space, and intersegmental spreading route via the CTS or endothoracic fascia. In conclusion, many findings in our study highly corresponded to outcomes of previous studies. Using the micro-CT, histological examination, and cadaveric injection, we can observe and verify exact anatomy of the DPVS, SCTL, and CTF, and lateral SCTL space. My team would try to apply micro-CT to investigate other complicated structures related to pain management. Yes, this is my contact email address. If you have any question, please send me. Thank you for your attention.